And now we're going to have the panel discussion, so if I can invite Drs. Terrault and Dr. Noureddin on the stage to the podium, as well as Dr. Quo virtually. And then we're going to have a few other participants, Dr. Julio Gutierrez, who's from Scripps, Dr. Jihane Benhammou from UCLA, Dr. Tien from UCLA as well. And then we're supposed to have some questions from the Zoom. I don't see any questions in the chat.
Are we taking off our mask?
Yeah, there's 2 microphones here, so people can come up and speak into it so they can hear on the...
So I'll start with Norah. There was an abstract at AASLD, Norah, from Taipei, looking at their VA population, and they had 10,000 patients on nukes, and about 600 relapsed when they stopped their nukes. So they stopped nukes according to their protocol, and they had a 6% severe flare and 0.6 death. Now, they included 10% cirrhotic, so we wouldn't do that in a cirrhotic, but I'm stuck with about 500 scientists or tech people in the Mesa and in La Jolla that are all on nukes, that read all the literature. They know Apostle data and they know EASL data, and so I have to spend half an hour, routinely explaining to them what the risk is about stopping nukes. And then I check their surface antigen and pray it's not below 100. Most of the time it's not. But if it is, then I kind of, they've been on nukes for 3 years, they're undetectable, they don't have cirrhosis. So I'm going to send them up to you. What would you do with those folks?
Yeah, I hope that I don't come across as somebody who's recommending withdrawal, because we're not. But we are saying that you can consider it in select individuals, and I think that's really an important message. So for sure not somebody with advanced fibrosis, but we need to look at that. And I really think the surface antigen quant should be the way we go forward. And you are right, there are few patients that have a surface antigen quant that's 100 or less. So if you use that, very few patients really will fall into the category where you might think about withdrawal. And what is interesting in the group that have that surface antigen quant under 100 is that's the group when you withdraw that you have a much lower likelihood of having ALT flares. So I think it's all about safety. The number you're quoting is nobody wants to have a death. Nobody wants to have a decomp that leads to a transplant. So really, how do we minimize, really bring that as close to 0 as possible? And I think the surface antigen quant is the way to go. The other thing is that you really just have to monitor them super carefully. And, I told you I got chest pain sort of like, taking people through flares. I think that's where it's really hard is there's not really good guidance about like when do you pull the trigger to put them back on the nuke. And, at the moment, most people are sort of just, winging it in terms of when they do that. And I think that's where I wish we had better guidance about like when to restart, because that could also help you. But I think if you eliminate the advanced fibrosis and really stick with using surface antigen quant, that you will, first of all, have much fewer patients that are going to be really eligible for withdrawal, and you're putting yourself into a camp where the risk for a flare that is serious is extremely low, pretty close to 0, I think. So that's how I would approach it. But, I think the other strategy of like waiting for the better drugs to come is also okay. Like the other way I was trying to sort of convey that, yes, the new drugs are coming. There's still 5 years plus where you're going to be prescribing. But if you want to just say to your patients, look, the field is rich in new therapies. We're certainly going to have something that's going to offer you functional cure in the future. Just hang tight. That would also be okay. And that's why the AASLD guidance is still saying, for new patients, just keep treating. So, but if you have somebody who's really like anxious to stop, I'm trying to give you some clues on how you might do it and maximize safety.
Good answer. Okay, second question, Mazen. Before AASLD, Mary Ranella showed a slide with 8 drugs in NASH drugs in the graveyard. So you presented data on 4 drugs in phase 2A, and there's, as you know, there's a bunch of drugs in phase 2A that all look promising. When they get to 2B and 3, they're dying. So there are 8 drugs that have failed from Gilead, Allergan, Novartis. You know the big and small groups. 2 drugs are left, semaglutide and Madrigal. So you just added 2 more drugs to the graveyard. So there's 10 drugs in the graveyard now. So we used to show this in Hep C, you know, the graveyard of failed drugs. But while we were doing that, we were making little progressive changes. You know, they were small. We were improving SVR rates a little bit. So there was some promise that kept pharma involved. But what's going to happen if Madrigal or Novo don't make their endpoint?
What's going to happen at Madrigal and what?
Or Novo don't make their endpoint? I mean, one of them has to show, it's clear the FDA wants reversal of fibrosis. It's not going to be good enough to show resolution of NASH, at least based on the OCA data, the Intercept data, because they didn't make the Subpart H approval. So,
Well, I mean, so Madrigal, let's talk about Madrigal for a second. Madrigal, the primary endpoint of their phase 2B that was published in first 2A to B that was published in the Lancet was MRI-PDFF. So the secondary endpoints were the histology that they met NASH resolution. A lot of their secondary data are very promising. So if they don't hit their phase 3 endpoint, I can understand that, although I think they will. That's my guesstimation. But, and I don't want to be biased to any company, but the other drugs like the semaglutide and the lanifibranor, they base the primary endpoint and then New England Journal studies on histology. So if they just replicate what they did in the phase 2B, they will get approval. And I'll give you the lanifibranor example. They did that within 6 months only. So I really want to look at things, the glass half full, and I really think we're going to get to approval soon because we have phase 2Bs that per the regulator that they're asking us now to do histology, and we have histology in the 2B. If we don't hit points, this is a disease that needs a treatment. It's an epidemic. I think we'll keep continue, but it will not be in a good shape. And a lot of people will not be interested, as you know. We will come talk to you what happened to hepatitis C, like when the SVR was 20, 30%, what should we do? But I hope we will not be in that boat because I'm optimistic about the phase 2B data from a lot of drugs. So I'm a glass half full person in general.
okay, last question for Paul, and Hugo, you can take this also. So Mike Charlton showed a slide at AASLD saying that 95% of the current patients being transplanted for alcoholic hepatitis on the UNOS database have cirrhosis at biopsy. And so they're really acute on chronic. So, and we're transplanting them, Hugo, you know our protocol, you wrote it, based on the fact that this is their first alcoholic decomp and they didn't have any warning and blah, blah, blah. But the biopsy is saying that's not the case. So, Paul, you want to take that first? And I'm sure you're seeing the same thing.
Yes, we are, and so, yes, but also I would just like to say that when we look at our program, it's presentation. We too, it is actually quite impressive sometimes when we look at the explants, although it's interesting to note that the fibrotic nodules we see in younger people don't seem to be as well circumscribed. But yes, I think we have to, when we explore transplantation for those with alcohol use disorder, it is in the context of a clinical presentation of the decompensation episode. That doesn't mean that they, had just, if you will, alcohol use disorder and then just had the hepatocellular injury without already having the underlying inflammatory, necrotic, and fibrotic sequela of chronic alcohol use. So to me, that is not so surprising. We'll have to see as time moves on and as more centers adopt the potential exception pathway policies. It will be interesting to see when this is reported more widely in a few years, whether or not we'll still see these same high levels of fibrosis.
Yeah, thank you for that question, Dr. Pakros. I have a similar feeling as Dr. Kuo. Although I think that we know the clinical syndrome of alcoholic hepatitis is a big liver. And so I think really part of the inclusion criteria of this population should be something like a liver, say, over 17 to 20 centimeters. If you're transplanting a patient that has a 12-centimeter liver under an alcoholic hepatitis protocol, it's probably not right. We're seeing that if we dare to biopsy these patients, that they typically do have a sort of feathery fibrotic pattern that the pathologist will call fibrosis, but it's not that dense, established fibrosis that we see in a cirrhotic patient. So I think that's the differentiator for me, is the size of the liver. And I really want to see that big, massive, I mean, we're seeing 27 centimeter livers. I call that the shack liver now.
Can I just make a comment, though? I'm not sure it matters, because in the end, what we're trying to do with transplantation in individuals who present with their first episode of decompensation, whether it's due to ALCHAP or unrecognized cirrhosis that now is acute on chronic, is that we're really talking about transplantation in the setting of alcohol use disorder. And I think it's not surprising that there is some heterogeneity in sort of those individuals presenting. Just as we see NAFL patients who present to us with their first episode of ascites, and they never knew they had cirrhosis, there are individuals who have alcohol use disorder in which they don't know they have cirrhosis. We underdiagnose that. So I'm not sure I care whether it's, I kind of care from the point of view of, understanding sort of natural history and outcomes, whether it's ALCHAP or a first presentation of acute on chronic liver disease. If they're sick and their MELs warrant transplant, I think we have to think about, how do we do transplant in the setting of alcohol use disorder? So for me, I'm a little less interested in sort of restricting. I don't think we should restrict it to ALCHAP. I think we should be thinking about how do we consider transplantation in people who have alcohol use disorder who don't recognize that they have liver disease. So I have a slightly different sort of take on it. Do you understand what I'm saying?
I do understand what you're saying. I think for me, what I imagine the difference we usually will be age, and that the patient who has alcoholic cirrhosis will usually be older. And they have shown different patterns of alcohol use post-transplant in those populations. So I think the opportunity there is, well, you have a very young person with a recent change in life, alcoholic hepatitis. You have a person who's been drinking 30 years. Could have they caught up with their alcohol use as they matured in life? And so I think that's the difference. But I agree with you that we don't approach alcohol use disorder uniformly or appropriately in most of our patients. And I would be willing to consider those patients too, just like you, but that's not the way our protocol is written, unfortunately.
Yeah, I would challenge your protocol. Right?
If you have somebody who was sheltering in place, for instance, and was just somebody who had some degree of alcohol use, but their alcohol use accelerated in the last year or two, and they had been working full-time but presented with cirrhosis, would you then decline that person for transplant if they were fully functional in all other aspects? Those are the patients that we certainly look to offer transplantation provided they meet our other criteria. And so I think I think it's, like as Norah said, it's still an evolving process, but I think, the important thing is to make sure that we offer to those who show the best stewardship of the organ an opportunity to have a therapy if they're medically refractory to the alcoholic hepatitis portion of their presentation.
All right, Bob, you have a question?
Yeah, thanks. It's a great morning so far. Thank you, everybody. One is a quick comment on the stopping nukes. I work with the Hepatitis B Foundation, and we survey about 10,000 people per year via email, phone calls, different types of consults. These are patients contacting the foundation for questions, and about 40% of patients stop their nukes on their own for different periods, sometimes permanently. Half the time, they don't even tell their provider until maybe 2 or 3 years out that they stopped. So stopping is happening in the background, just so everybody's aware. We think we're in control, but we're not. So 2 fast questions, maybe fast, maybe not. So I really am interested in change. And this one goes, I think, more to Norah about ASLD, hepatitis B guidelines, morphing like we did with hepatitis C guidelines. There's so much data coming out, it really should be online, I think, and updated every 6 months. And the second question, more to the panel, is when are we going to change from NAFLD to MAFLD?
I'll maybe take your first question, Bob. I'm completely on board with that. Like, there's a lot of, I'm getting a lot of feedback, and I actually am hearing it loud and clear that there's a need to simplify and to be more nimble in how we are communicating information about how to manage hepatitis B. And guidance documents take, they're long and laborious, and getting them published and all of that is really, it's a year to 2-year event. That's not going to work for the very rapidly changing field of Hep B. So I really envision that there'll be something very similar to the HCV guidance that will be online and be more nimble going forward.
The problem with changing NAFLD to MAFLD is we need consensus from all societies, ASLD, EASL, and other societies. There's ongoing effort to reach that consensus on NAFLD and MAFLD. I'm not aware of its details. Dr. Terrault might know through her ASLD leadership. I think it's coming in June, that's all I know. But it's in the dialogue. There are people with it, there are people against it. Some people say, well, we did trials with NASH and all this, and now we're gonna call it MASH and all that. So other people, they're like, well, it's a systemic disease, and there's some differences, subtle, we just did meta-analysis, there are subtle differences. So Dr. Terrault, I don't know, you were gonna say something?
Yeah, there is a consensus meeting planned, bringing in all the players, like EASL and the Asian groups, and to bring everybody together, because for one group to decide without us all deciding is not a good idea. So hopefully we'll have an answer this coming year.
Yeah, just imagine you're gonna tell your patient you have MASH, so.
I have a couple of questions from the chat. I just wanted to make sure that we include the people that are virtually involved. So first question for Dr. Dong and Dr. Benhammou. How do you work up a patient with a big liver, normal liver tests and nothing else? Because I see a fair number of consults like that.
Sure, I can start. So I have a VA-based practice in addition to being at UCLA, so I think working in a different healthcare system matters in terms of resources and the types of patients that we see. So, generally if they come to our clinic, and we have seen patients come to liver clinic with an enlarged liver, normal liver tests, or abnormal liver enzymes and enlarged liver. Number 1, 2, and 3 is history. In terms of, risk factors for any infiltrative process, most commonly being fatty liver. Alcohol is a big one, especially at the VA, and a lot of times it's both. It's not, we like to think of diseases as one or the other and thinking about outcomes, but generally they kind of come together. So, we start with the history. We do, obviously, laboratory workup. I generally don't check ANA, SMA, things that I think are not going to be of value. They shouldn't cause an enlarged liver, and we don't usually see it in our patient population. We have a fiber scan readily available to us, which is very, very easy for us to do. So we start with a fiber scan. which gives us, and generally they'll have an ultrasound, obviously, before coming to us, or other cross-sectional imaging. So the FibroScan is an easy first step. Because we have the luxury of having the MR elastography, which I know is not necessarily common practice everywhere, but I generally look at the BMI threshold, and anybody with a BMI of 35 or above, I tend to choose the MRE first, just because I know of the limitations of the FibroScan. Or sometimes they'll come with the FibroScan, and you just have to be aware of how to interpret that data appropriately, including looking at the IQR, measuring the FIB-4 score. I don't think looking at only one non-invasive test is the right approach. I think you should look at two and start there. But liver biopsy is rarely needed in those instances, but it kind of depends on that initial workup.
Yeah, no, I completely agree with that. In addition to, ruling out all the other etiologies for infiltrative diseases, just thinking about prevalence in regards to the obesity rates in the U.S. alone, which is, I think, right now 1 out of every, 40%, I think, is the current prevalence rate. The majority of patients that come with an enlarged liver in your practice is most likely going to be from NAFLD, if not from alcohol.
Okay, want to go ahead?
Hi, it's Kelvin from Kaiser Orange County. I have 2 questions on Hep B for the whole panel. The first one is, we do have patients that on antiviral for Hep B and got surface antigen and lose surface antigen, and viral load is negative. We check the quant is less than 10. So what would we do in that situation? Should we have a conversation of stopping therapy at that point? Should we keep it going for a few years? It's for the whole panel.
I'd be really interested to hear what the panel says about that.
When you say less than 10, you mean less than 10 but detectable?
Less than 10 IU per ml of the quant.
Of the surface antigen quant or HBV DNA quant?
Of the surface antigen quant.
Yeah, okay.
Oh, surface antigen, I'm sorry.
I'll answer, but I think I'd be interested to know what people do in their practice right now. So based on the data I showed you, that's a patient in which I think you could stop if they're not advanced fibrosis, and follow them closely. And I think they have a high likelihood that they'll lose surface antigen over time. It's or not, but I think you could probably safely take them off treatment. There are also data that show that the quant is not only predictive of will they get to functional cure, but what's their likelihood of getting a clinical or virological relapse. So the lower the quant, the less likely it is they're going to have those events as well. So you could consider it. Have that conversation and let patients know that at this level, there's a high likelihood that they could come off treatment safely, but they need to be monitored carefully and be ready to re-intervene if that doesn't occur.
Dr. Terrault, my question for that is, aside from not having to take the pills and the change in the surface antigen status, what would be the clinical benefit for that patient if they were able to achieve that functional cure compared to if they just stayed on their nuke for the next 5 years?
Yeah, so the likelihood of liver-related events, and probably cancer being the big one, is lower if you get to surface antigen loss. So, it really is a marker. Losing surface antigen is a marker that you have your intrahepatic levels of replication are very low, right? Because you have that degree of immune control. cccDNA is still there probably, but the data is really clear that there's an additional reduction in your risk for liver cancer when you lose surface antigen. And it's probably about sort of the depth of remission, right? This idea of kind of deep remission, that when we have a suppression of HBV DNA in the blood, that's good. But if you lose surface antigen, that level of viral suppression is much, much lower. And that probably is why we see this conversion in terms of lower rates of HCC. So if we want to get to the lowest possible rates of HCC, which is the event that really is our worry in people on nukes, surface antigen loss matters.
I'll tell you what we do in our practice. We're following the ASLD guidance.
Yay!
And I think a big part of it also I mean, I hate to say it this way, we're legally covered by our guidance, so.
So, but you
Until
know,
that change,
Yeah.
Until you move
you're,
to
you're,
a PASL.
you're the expert in this field, so if things happen, you can say, I've done this research, this and
Yeah.
that. So I think a lot of people in this room will feel like even there's EASL guidance or Basel guidance, they're most comfortable with the ASLD guidance, and the withdrawal will happen once that change. They
Yeah.
will follow the algorithm.
Thank you.
we're aware
This-
of that.
And the second question also Hep B. So, like when we have a patient with core positive, surface antigen negative, viral load negative, when we see those in clinic, we're just like, okay, you're probably exposed to Hep B, and that's about it. But now we start talking about functional cure, steroid cure. I think that question is kind of resurfaced, and we're just gonna, we know there may be a cccDNA around with these patients, so are we just gonna just let it be and, not seeing them until they're on immunosuppressed medications, then we're gonna start seeing them again, but otherwise, are we doing surveillance for these patients? And if so, what are we gonna do? And how long?
I can try to take that one. I think this is actually an area where, I'll be honest, the guidance is a little fuzzy, right? Because it's a little bit of an unknown. But my personal approach to this is a patient who has lost surface antigen and is core positive alone, that is somebody who has functional cure, right? So that's by definition somebody with functional cure. They can, of course, reactivate in the setting of immunosuppression, and they can actually reactivate naturally as well, but that's very low. Once you get to functional cure, you stay there. That's largely what happens unless you're suppressed. But sometimes you have somebody land in your practice and they have their core positive, right, surface antigen negative, but that patient is certainly in a risk group where they could have had chronic hepatitis B for 4 decades before you saw them, right? And they could have lost surface antigen naturally. So we know from natural history studies the rate of losing surface antigen is about 1% per year. That's the number. It's been very well established. So some patients who have chronic hepatitis B do lose their surface antigen naturally. So I'm always a bit, when I have somebody who lands in my practice, they're 50 years old, they come from an area where they likely acquired their hepatitis B as a child or an infant, I'm sort of struggling then. Like, did they lose it last year, their surface antigen, or did they lose it, very early in life? If they lost it very early in life, their risk for cancer is essentially 0. If they lost it last year, there's still some risk. And maybe that person needs to go into surveillance. So I've really struggled with this. And the guidance doesn't provide guidance on this because we actually don't have good data. So what I do in my practice is I get a FibroScan, right? And if they have evidence that they have chronic liver disease, then I survey them. Now, is that the right answer? I don't know. I'll be honest. I'll be interested to see what it is. But I do use, FibroScan is a nice tool for us now. And if I have somebody who's got evidence of chronic liver disease, and I think, okay, maybe they lost their surface antigen last year, and I'm going to roll them into surveillance because I think they're still at risk.
I mean, it's also very tricky, Dr. Noureddin. I mean, a lot of these patients also have fatty liver on top of it.
Okay.
And so that fibrosis score that you get, or the FibroScan score that you get, it could be from
Correct.
fatty liver as well.
Yeah, okay, so that's tricky, I'll admit. They have a high CAP score, and I think that that's driving the fibrosis. I might think about it differently. But you see where I'm coming from, right? I'm trying to find a patient who I think may have lost their surface antigen very recently, and therefore is a person who really still is at risk. But, this is a kind of a bit of a data-free zone, to be honest.
Well, the fatty liver will make it easy, actually. You're going to monitor them for liver disease, and you want to monitor their fibrosis. But I learned something. Now I'm curious if I should FibroScan my core positive. I don't.
Well, but core positive is where you're pretty convinced they were infected as a child, right?
Yeah.
So, I think that's we all see a lot of those.
Like the
right?
recent ones.
It's a lot of fibroscans to do.
Well, FibroScan's a good tool for many things, including NAFLD. So,
I'm going to do one more question from the chat before. Can I just, why don't you go ahead and we'll do the chat after. Yeah, just one for Mazen and everybody else about vitamin E, 800 units for NAFLD patients, and whether you're using vitamin E, and also why not use it in cirrhotics and diabetics.
Sure. So, and I also would like Dr. Benhammou to share with me her opinion. She's another NASH expert. So, vitamin E, I still use it. It's still in the guidelines for NASH, biopsy proven. That's the current guidelines. By the way, the guidance is going to be updated this coming year, so stay tuned for that. The reason why it's not used for diabetics, there is a study from Ken Kusi. I don't remember the journal. I want to say it's Annals of Internal Medicine. He did study in diabetics, compared pioglitazone vitamin E in diabetics. Histology study, vitamin E did not work as well, and that's why the most recent guidance said PO, for diabetics, PO only. For cirrhotics, you don't use either. There are not enough studies done in cirrhotics for either PO or vitamin E. There was one retrospective analysis. I think Dr. Cole was involved in this, or the Indiana group was involved in this, that they did vitamin E in cirrhotic patients. It improved outcomes in NASH cirrhotic patients. I think that study needs to be replicated or randomized, but some people use vitamin E in cirrhotics for that reason.
That was a retrospective
Correct.
cohort study looking at cirrhotic patients, and they just looked to see what the liver-related events were in those who were on vitamin E, and vitamin E seemed to have lower rates of liver-related events. It was not prospective.
No, I said retrospective. Sorry if I said prospective. Yeah, it was a retrospective.
Oh,
Yeah, it was a retrospective, and I think that's why it needs to be replicated in a prospective. And it's not endorsed by the ASLD guidelines, but I think it was an excellent study published in Hepatology. And I wonder what Dr. Benhammou does in her practice.
Yeah, so I also tend to follow guidelines. Again, because I'm at the VA, though, I will say that transplant is usually not an option for our patients for many reasons. So if I have an F3, F4, then sometimes I will start vitamin E based on that retrospective study. I mean, it was a very well done study, propensity, match study with a 10-year follow-up period. So I know we don't have any prospective data, but I thought it was a good study to refer to. But one thing we do notice is actually a lot of our patients already come on vitamin E before they see us in clinic. And so they do their own research, and they say, I'm taking this vitamin E, and it's a big black box as to what we should do. I do counsel them on the risk of prostate cancer, again, because I tend to see older male patients, and they should be aware of that. I think the risk for hemorrhagic stroke is not as strong, but I do mention both risks to the patients.
Thank you. We have just time for a couple more questions. So Amandeep, who's been patiently waiting.
Hi. As I sit here and getting excited about what's coming our way, we are definitely diagnosing more patients with chronic liver disease or some sort of fatty liver disease. So my question for you, Mazen, is, we still have lifestyle modification as part of treatment. And I want to ask you this question about, as we are diagnosing all these patients with fatty liver, what is the workforce development here? Do everybody has to see a hepatologist who has, or there is some room of primary care endocrinologist or gastroenterologist?
Yeah, I'll quote data actually.
And
sorry.
just wanted to make it sure that we really need to have some little guidance about when you have early disease, which is less than F2 based on FibroScan, what we have. How do we follow those patients? And then how do we follow F2s? And then, of course, we know how to follow advanced cases. So
Yeah, I will quote data that just came out. Two of them, the AGA guidance that was published in Gastro Diabetes Care, and there's also EASL guidance on how to use non-invasive testing. So the AGA guidance, it's called Call for Action. Dr. Canwell is the first author on that paper, and it stratify how you refer patients to which will be like for you to implement in the Kaiser system. So it says how you refer patients type 2 diabetes metabolic syndrome, and then it calls for doing the FIB4. And the AGA guidelines, less than 1.3, it stays with primary care. More than 2.67 goes directly to a hepatologist. For your system in particular, the people that falls in the indeterminate zone, 1.3 to 2.67, they get a FibroScan and it tells you what's the FibroScan values that go to the hepatologist. It's a nice paper to kind of refine who gets referred or not. The European does it slightly different, not that much, but they are these two papers, one in JHAP and the other one is in gastro and diabetes care. So I don't know what others feel about
Nora, the
that.
reason I'm asking is colonoscopy age cutoff is now 45, right? So screening colonoscopy. So the gastroenterologists are very busy doing scopes. So we are diagnosing all these patients and just wanted to see that if there is more call for action
I'll
to
send you that paper.
empower more primary care physicians to take care of fatty liver, because not all diabetics go to endocrinologists. So just wanted to see the thought of the group as we are diagnosing more patients. And I'm excited. We are doing more transplants also, as we heard. So there's so many hepatologists we have. So I just wanted to put it out there, even though I just don't know what's the real, how we plan next 10 years for hepatology community.
Yeah, I'll send you that paper. What do you, Jihane, what do you guys do in UCLA for primary care and endocrinologists? What?
There's not really a care pathway at this point. I think we're gonna have to figure out as a community what to do. But, there's only one FibroScan that Dr. Yanni does at Santa Monica, and MRE is very expensive. So there's no real guidance necessarily with the PMDs at this point.
Yeah, so the other way, and I just want to make sure I don't recommend test for this to others. After the FIB4, the people that they fall in the indeterminate zone, if you don't have a FibroScan, be on the look for tests that they can give you the second answer, that we call it the sequential testing. So if you need an answer, there will be tests coming that they can give you that second answer.
Like ELF and all others.
Yeah, so that others, so a lot of people in the field, experts, they're saying that second test can be serum-based, and I'm happy to send you that paper. Canwell is the first author, just came out.
There's also a lot of good data on sequential testing. So for a lot of patients, at least in my practice, if they have F2 or lower, we would actually tell the PMD, look, you can get a repeat FibroScan in 1 to 2 years or 2 to 3 years, or MRI every 3 to 5 years, depending on your resources available. That way, it gives the PMD at least an idea that they should at least be followed, at least because they can develop and they can progress, and it gives at least the PMD some form of instructions on ways that they can follow these patients over time. And then obviously if they advance, then that's a point where hepatology referral should be warranted.
Yeah, Dr. Sahota, one thought I have too is, Mazen presented this data too with the cardiovascular events that we're seeing in patients who have fibrotic disease. And I think we may start to think about this condition not just as Mazen's disease, but there's going to be some kind of metabolic group that has to deal with these patients, because they'll end with renal failure, cardiac failure, and liver failure. And you just don't know who's going to die of which one, right? So maybe those patients need to get funneled towards some special sort of clinics that deal with metabolic disease in general.
Thank you.
Just quick one.
Quick question for Norah. With hepatitis B, DNA integration happened early in the disease, and we know HBV is an oncogenic virus.
Mm-hmm.
So stopping HCC screening for these patients carries some risk even after the S antigen loss, because we don't have any therapy to get rid of that integration of the DNA of the virus. So stopping therapy for after S antigen loss carries some risk. And just a comment, I usually discuss it with a patient that your risk of liver cancer is not zero after losing hepatitis B surface antigen. Would you agree?
Yes, that's what I was getting at when I was sort of commenting on the core positive only patient who may be a patient who lost surface antigen sometime over their career of chronic hepatitis B. But what I don't think we have data, in fact, there's no data that suggests keeping a patient on an NA changes sort of the risk related to the integrated HBV DNA, right? So, but for sure. So there's still risk after loss of surface antigen Interestingly, it's mostly related, though, to the stage of fibrosis. When you look at the studies that have been done in patients that have lost surface antigen and look at liver-related events, it's also linked with the stage of fibrosis at the time that they lose surface antigen. So that's why I was getting at this idea that we should maybe survey those that have advanced fibrosis after loss of surface antigen, but I think that there's less data to support doing that in every patient, right? So it's both. So integration matters, stage of fibrosis really matters. So even after surface antigen loss, there's still some risk, yeah.
All right, so I think we need to end this session. So thank you, everybody, the panelists and all the speakers.